Okay, we're going to go over a few other gastric disorders. They do get tested, but because these are slightly lower yield, you can expect that the way these are going to be tested is going to be pretty superficial. So we're not going to spend too much time going into the details of these, but I want you to be able to recognize them because they can come up either as correct answer choices or as wrong answer choices. And it helps to know all of your diseases because you can eliminate wrong answers too. That's one way to get at the right answer, right? If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button on the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. And certainly feel free to subscribe to my channel, and you will get notifications as I put more and more videos up. Okay, so these are all the causes of epigastric pain. That's pain around your belly button. So we're going over some of the others here. Now, remember your alarm features, and these are just some of them, but if you've got a patient with belly pain and weight loss or anemia, heme-positive stools, early satiety, odynophagia or dysphagia, or they're older than age 45 or 50, you got to be thinking of more severe causes. Usually with these alarm features, it is an indication to scope them depending on, if you got odynophagia and dysphagia, you're going to do an upper scope. If you've got a patient with heme-positive stools, you're going to do both an upper and a lower scope. Now, anytime I've got a patient with GI symptoms, personally, I go straight for the stool guaiac test because you can rule out a lot of things that way. And it's very easy. You just do it in the clinic. All right, so here we have 4 distinct vignettes here, and we're going to talk about all these. You can pause this and look at this if you want, screenshot it. We'll go over each of these things. Zollinger-Ellison Syndrome, you probably remember from step 1. This is a malignant gastrin-secreting tumor. Usually it's in the duodenum or in the pancreas, and it results in increased secretion of acid. Remember, gastrin increases acid secretion, and that's obviously in the stomach. This results in recurring ulcer formation despite treatment for peptic ulcer disease. So you maybe scope them or you're treating them presumptively for ulcers and it's just not working. And then what typically happens is you go in with an upper scope, EGD, and you look in their stomach and maybe you don't see anything, and then you get to the duodenum and you see some really nasty ulcers. That is typical for Zollinger-Ellison syndrome. So because of the excessive gastric acid levels, another thing that can do is it can deactivate pancreatic enzymes. So if you're deactivating lipase, for instance, you're not going to be able to break fats down and you can get a steatorrhea. Okay, so diarrhea can be seen with this. So this ongoing gnawing abdominal pain along with diarrhea is a tip-off for ZES. And then remember the other thing I told you, multiple or big, deep, ugly duodenal ulcers is very typical for ZES or for any high gastrin state. So like I told you, again, this is really useful for your exam. This is a big hint here. So what do we do for diagnosis? The best initial diagnostic test is a fasting gastrin level. What do we expect to happen to gastrin when we fast? It's supposed to go down, right? Gastrin helps us digest. If you don't have anything in your stomach, gastrin level should go down. If you have a high gastrin level and you're fasting, that is suggestive of ZES. You should also get a gastric pH. Now, once you diagnose this, then your next step is an abdominal CT. We're looking for metastasis here. So you particularly want to look at the liver. The differential is just regular old peptic ulcer disease. Typically that's going to remit with therapy. And then multiple endocrine neoplasia type 1. Remember, that's parathyroid, pituitary, and pancreas. The pancreas can be the gastrinoma. The treatment, if it's localized, we go with a high-dose PPI, surgical resection, and you may add octreotide if the PPI is not enough. For metastatic disease, this is cancer. So we typically treat it with chemotherapy, but you will not need to know how to do metastatic treatment. Just know with ZES, we have high-dose PPI and octreotide along with surgical resection. Okay, dumping syndrome. Look at this. Do you know what this is? This is a Roux-en-Y gastrojejunectomy. Why do we do this? This is gastric bypass. And one of the complications of this is dumping syndrome. So what is dumping syndrome? Dumping syndrome is where the stomach just throws way too much chyme into the duodenum all at once. And the duodenum's like, whoa, what's going on here? I got all this stuff. I'm going to just flood the blood with insulin. That's a problem. Okay, so what happens right away? Well, you get all this chyme into the intestine, and what's going to happen is osmotically that's going to draw fluid into the duodenum. And so that can cause some diarrhea, but more severely, it can cause hypotension and bloating. Those are the early symptoms, and it happens almost immediately after eating. And then a few hours later, what happens is the duodenum says, well, look, I got all this stuff. I need to release insulin. It releases way too much. They become hypoglycemic. And that is the most salient feature of dumping syndrome. So everything we expect with hypoglycemia, sweating, listlessness, anxiety, nausea, dizziness, and so forth. And I would actually say that these two are not hypoglycemic syndromes. Okay, so the diagnosis here is a gastric emptying study. That's how it'll come up on your exam on CCS. However, what this actually is, what we call it in medicine, is a dual-phase gastric scintigraphy. But on your exam, look for gastric emptying study. The treatment here is just dietary modification. Smaller, more frequent meals to reduce putting all that food into the duodenum. Gastroparesis. This is usually caused from chronic uncontrolled diabetes, which has an effect on the autonomic nervous system. The vagal nerve is not working properly. This decreases peristalsis. The stomach contents are going to be retained, and so you got a full stomach all the time. So the symptoms are exactly what we'd expect with a full stomach. They're going to have some postprandial epigastric pain, bloating, vomiting. Their stomach is full, so they try to eat, and they just, they can't eat anymore. So early satiety and stuff like that. Now, remember, early satiety is one of our alarm symptoms. So a lot of times we're going to end up scoping these patients anyway. A lot of times there's also unintended weight loss, another alarm sign. And why would we get unintended weight loss? Well, because they can't eat as much because their stomach is just, everything's backed up there. So most of the time we end up scoping these patients and it comes out completely normal, although there may be food in the stomach remaining. If the diagnosis is apparent based on the symptoms, then generally we can just diagnose them right there. However, the most accurate test is again here a gastric emptying study, but unlike in dumping syndrome where you have very quick emptying, here you're going to have obviously delayed emptying. The treatment, always remember to stabilize the patient. Sometimes these patients could be hypotensive, so give fluids. And that's also here with dumping syndrome. If they're hypoglycemic, the best initial step in management is going to be to give dextrose. But here, the most accurate test is a gastric emptying study. We stabilize them with fluids if necessary, if they're hypotensive. Dietary modifications, again, more frequent and smaller meals helps the stomach because it doesn't have to work as hard. Metoclopramide. It is a prokinetic agent, and this is really useful for them to help kind of move things along. Antiemetics can be given as needed, and then diabetes education and control should always be included because most of these patients are uncontrolled diabetics. Finally, functional dyspepsia. You probably won't be tested on this. This is the ultimate diagnosis of exclusion for epigastric pain, so just know that. Usually with these patients, you've done a battery of exams, you've done upper endoscopy, you've done a barium swallow, maybe you've even done gastric emptying studies, everything comes back normal. This is really difficult to treat because we don't know what causes it. So you still want to monitor these patients, though, for alarm symptoms because sometimes you may have an actual diagnosis, but it's not apparent right away. So monitor these patients. I doubt you will be tested on functional dyspepsia.